Hi, I'm Natalie Wilson. I'm a third-year resident at the University of Minnesota, and I'm here today with Dr. Mohammad Bilal to discuss our recent article published in Gastrointestinal Endoscopy. Dr. Bilal, could you introduce yourself?
Thank you, Natalie, for your introduction. I'm an assistant professor of medicine at the University of Minnesota and an advanced endoscopist at the Minneapolis VA Medical Center.
Our article, which was titled Outcomes of Cold Snare EMR of Non-Ampullary Duodenal Adenomas 1 centimeter or larger, is a large multi-center retrospective study evaluating the outcomes of cold EMR in the duodenum. Dr. Bilal, what inspired you to do this study?
Yeah, thank you, Natalie. I think that as we have seen over the course of the last few years, that cold in EMR has taken up widespread adoption in the colon, and we have seen a few single center studies and even some small multi-center studies looking at cold EMR in the duodenum, but there's still limited literature available on that. To see its widespread adoptability and outcomes, we felt that it was important to look at it in a multi-center setting so we can see and assess the generalizability of the results, as well as include endoscopists and sites from various backgrounds, including community medical centers, academic medical centers, and having experienced mid-career and early career advanced endoscopists participating in our study.
Wonderful. And would you be able to elaborate on how this study adds to the current literature that's out there, the current knowledge in the field?
Yes, I think that this study, which has the largest number of patients included so far that have undergone cold EMR in the duodenum. We had 127 duodenal adenomas that were included in our study that underwent cold EMR. So I think, like I said, the fact that this is a multi-center study and it has such a large number of patients allows us to assess the true outcomes of cold EMR in the duodenum in our field, which we see in routine clinical practice. So we saw that the recurrence rate, which was our primary outcome, was about 31%. And everybody, I think the previous studies have shown the safety and efficacy of this technique, but I think the real outcome that we need to know where the difference between conventional EMR or hot EMR and cold EMR in the duodenum occurs is the recurrence, because we know by definition that cold EMR is a safer technique. So the fact that our recurrence rate was 30%, which is comparable in some studies where conventional EMR was performed, I think that shows that this is an acceptable outcome. There is certainly heterogeneity that is inherent to the design of any retrospective studies that could have contributed to it. But I think it does show that the technique is definitely here to stay.
Absolutely. And what were some of the other kind of key findings of the study that stood out to you?
Yeah, like I think that the clinical and the technical success rates were very high, as we talked about the recurrence rate already, and the adverse events. We only 5 patients had adverse event, and which were mostly mild intra-procedural, and 1 patient only had delayed bleeding. And I think that reinforces the safety of cold EMR in the duodenum, because delayed bleeding in the duodenum is a big concern during conventional EMR, and there were no cases of perforation, which again validates what other studies have shown in regards to the efficacy, the safety of cold EMR in the duodenum.
Absolutely. And I think another interesting point that we found were that the predictors of recurrence, that 30% recurrence rate you were talking about, were the presence of high-grade dysplasia. And I know some other studies have demonstrated that polyp size, 20 millimeters or larger, is associated with recurrence. And in our study, we found that it was associated with recurrence, but on multivariate analysis, it was not an independent predictor. It didn't quite reach statistical significance.
Yes, I think that's very important, because it shows that it's sort of down the line, as we get more data on cold EMR in the duodenum and there are more prospective studies available, I think it would be important to identify that what are the predictors of recurrence, and maybe if every patient, you cannot do cold EMR, but it will identify that it looks like the vast majority of patients, we can definitely do cold EMR in the duodenum.
Mm. And what do you think the potential long-term impacts of adopting cold EMR for duodenal polyps as a standard procedure will be?
Yeah, I mean, I think that remains to be seen, because truly we will need, as these studies are retrospective, so there is heterogeneity in the data, and truly a randomized controlled trial would be critical to see what it is. But I think that the safety is a big thing, and I think the other thing that our study alluded to is that 70% of patients had follow-up, so that's a pretty good follow-up compared to other studies that have looked at cold EMR in the duodenum. And majority of the patients who had recurrence, about 75% of them were managed on a second endoscopy. So I think the key question that arises in our field about adoption of cold EMR in the duodenum is balancing the risk of doing conventional EMR using heat in the duodenum with the risk profile that we know that it increases the risk of delayed bleeding and perforation compared to just the need of a second endoscopy. So a lot of patients for other issues in the foregut, for example, in Barrett's, we routinely do every 3-month endoscopy to treat Barrett's and RFA. So if majority of the recurrence with cold EMR can be managed with a second or even third endoscopy, is that an okay price to pay, given that this procedure is exceedingly safe, as our study and other studies have shown? So I think this remains to be seen, but I definitely think that is another big take home from our study, is how many procedures were needed for complete eradication.
Absolutely. And I also think, figuring out what type of patients might be best for what procedure, there are different patient factors that might influence which procedure type you'd want to go with. Could you elaborate on that a little bit more?
Yes, I think that like you said, that if someone is on anticoagulation, if it's a difficult position in the duodenum, sometimes in D3 or D4 where you feel like closure will be challenging, or just because of the nature, if a patient lives really far away, they're really old, and you don't want to put them to those risk of adverse events, I think in those cases, definitely this study reinforces that cold EMR is definitely an acceptable alternative. Yes, the recurrence rate is about 30%, but that's acceptable in those patients. So I think that it does definitely provide that, if not comparable, it is definitely a reasonable alternative choice for resecting duodenal adenomas in select patients.
Absolutely. What are some of the procedural advantages of performing cold EMR in the duodenum?
I think the biggest advantage of cold EMR is the safety. And then even though a majority of a decent number of patients in our study did undergo closure, defect closure, but when you're doing cold EMR, defect closure is typically not performed unless the endoscopists feel there is increased risk of bleeding, and that definitely saves a lot of time, a lot of cost. You can just use the same just an injection needle on a snare, versus if you're doing duodenal EMR in the conventional duodenal EMR, sometimes you need clip closure or other through the scope suturing devices, which certainly add time and cost to the procedure. So I think that's probably one of the biggest advantages of cold EMR.
Fantastic. Thank you so much, Dr. Bilal. And for those of you interested, you can see the full article online on gastrointestinal endoscopy. Thank you.
Yeah, thank you so much, Dr. Wilson, and congratulations again on